Good morning. I'm Namrata. I'm presenting on behalf of Medicine 2. We'll start with the history. I'm presenting the case of a 39-year-old gentleman who was a service center employee from West Bengal. He was hypertensive for 4 years at presentation to us. When he presented, he said in 2017 he had right knee swelling and redness, and then following that developed bilateral ankle pain, for which he took homeopathic medications for a period of 3 to 4 years intermittently. In 2021, he developed 2 episodes of redness of his eye associated with pain. And in 2023, he developed lower back pain, bilateral shoulder pain, with an aching sensation that was predominant in the morning for about 1 hour and bettered on movement. He did not have any history of loose stools, blood in stools, altered bowel habits, or weight loss. His family history wise, his late chronic kidney disease and was on maintenance hemodialysis, but they died of an unknown cause. On physical examination, his pulse rate was 96 per minute. Blood pressures were 140 by 80, respiratory rate was 16. There was no pallor, excess lymphadenopathy or pedal edema. There was a healed scar of about 3 centimeter size on his right shin. There was no red eye, no active skin lesions. Musculoskeletal examination, he had significant enthesial side pain on bilateral anterosuperior iliac spine and first costochondral junction, as well as his Achilles tendon. He was Schober's positive and Faber's positive on the left. Other systems examination did not reveal any significant finding that added to our case. So the symptom complex in this gentleman is a chronic illness with red eye that could either be due to conjunctivitis or uveitis or dry eye. A macroscopic painless hematuria. Sorry, I didn't mention that. At presentation to our hospital, he presented with macroscopic hematuria. And an inflammatory axial and peripheral arthritis. Can I ask for some differentials at this point? Sorry.
To the slide. The presentation. Just go to the presentation.
Go to presentation. Yes. That was this one, the one that opened.
Go back.
I don't remember. Sorry. Okay, we'll discuss some of these now. I'm screen move out. So
இது போனங்களா
இல்ல நெக்ஸ்ட் ஸ்லைட்.
என்ன ஓட்டாரு இது இல்ல லேப்டாப் வாங்கிட்டு
இங்க ஆஃப் பண்ணணுமா? இன்டர்நெட்
லேப்டாப் ஓடுறது
Just what?
லேப்டாப் ஓடுறது
Yeah, just to
hand.
control all the with the taskmaster. So close it. Shut down the PowerPoint and then fresh and then start.
இதுல Sorry, so some of the differentials that we all considered that we had already discussed. So infective and post-infective causes. So the first column is differentials that can explain all three of the symptoms along with the chronicity. As the second row is illnesses which might not be able to explain all of the symptoms fully or the chronicity of it. So tuberculosis, hepatitis B with polyarteritis nodosa, HIV with arthropathy are some of the infective causes. Inflammatory causes are very wide ranging. Many of you had said so seronegative spondyloarthropathy, either Angst-Pond or IBD associated. Systemic sclerosis with the secondary Sjogren's with renal involvement, polyarteritis nodosa, Behçet's with glomerular disease, cryoglobulinemia. Malignancy wise, urothelial malignancy with bony mets causing his early morning pain, and paraneoplastic arthritis and uveitis or scleritis. Autoimmune in sarcoid genitourinary granuloma are known to cause macroscopic hematuria. Other things which are less likely, infections like herpes simplex, gonococcal infections, but the problem is this history is very chronic, some 3-4 year history. Myeloma, but macroscopic hematuria is very rare in myeloma. So investigations wise, hemoglobin was 9.3, creatinine was elevated at 1.63. He had significant proteinuria. At 24-hour urine protein was 1.6 gram, and urine for dysmorphic RBCs showed 49% dysmorphic RBCs in the urine. He was BBVS negative, complements were normal, C4 was mildly elevated, ANAs, ANCAs, SSA, SSB, anti-RNP, cryoglobulin, serum electrophoresis, bone marrow examination, all of these were non-contributory. This next picture is an X-ray we took of his SI joint. So as you see, the left SI joint is almost fully obliterated. There's a bony ankylosis there. And joint space narrowing is seen on the right SI joint. Also on further probing, we had found that he had done an HLA-B27 outside, which was positive. So we went ahead with a renal biopsy, which showed increased staining for IgA and showed focal proliferative and sclerosing IgA glomerulonephritis. So the final diagnosis was an ankylosing spondylitis associated with IgA nephropathy. Just a little about this. The association of spondyloarthropathies, both axial and peripheral, with glomerular diseases is being increasingly described. So this is a paper from Paris in 2020, which looked at outcomes of IgA nephropathy in a cohort of 32 people that they diagnosed with spondylitis. Median time to diagnosis of IgA nephropathy post the diagnosis of SPA was 10 years. And of about 5.9 years, 4 of them had become end-stage renal disease, and 41% of patients had experienced more than a 50% decrease in GFR. The other thing is the SPA-associated IgA nephropathy is associated with a poor renal outcome despite use of steroids. And even therapies like tumor necrosis factor inhibitors are associated with development of IgA nephropathy in ankylosing spondylitis. Another paper from 2022 in Portugal that looked at biopsy-proven kidney disease in a cohort of people between 1985 to 2001 who had kidney biopsy-proven renal disease, and out of 15 people, 2 of them with ankylosing spondylitis had IgA nephropathy. And this is the last one, a 2020 BMJ case report that described IgA nephropathy in a well man who was treated, a man with ankylosing spondylitis in remission who was treated with TNF-alpha inhibitors. So they've said that the renal involvement in ankylosing spondylitis can range from 4.5% to 35% depending on the population studied. It is more in Asians than Caucasians. The most common involvement, renal involvement, is amyloidosis, and after that is IgA nephropathy. Despite treatment with corticosteroids, though, these people often progress to end-stage renal disease. And anti-TNF therapy, the role is debated in treating Angst-Pond with IgA nephropathy. So my take-home points are autoimmune disease can at many times occur together. So once you diagnose one, you have to be on the lookout for other associated autoimmune diseases. Ankylosing spondylitis has many extra-articular manifestations, as we know, including uveitis, psoriasis, and chronic IBD. But more rarely, there are associations with lung, heart, and kidney disease as well. Among renal manifestations, amyloidosis is the most common, followed by IgA nephropathy. Thank you.
Thanks, Namrata. Are there any questions from the audience? This man's family history of CKD, was that relevant or just incident?
But he didn't have details of what his cousin had. So
We don't know. But there's no family association with IgA nephropathy.
No.
The other reason that it's complicated is because of how much, NSAIDs being the treatment in Angst-Pond, and how that might all, predispose to worsening renal disease. Thank you. Next case, the Cunning